And as the director of the Intracerebral Hemorrhage program here in New York at Mount Sinai, I've been tasked over the last 10 years with developing a program to optimize the surgical and non-surgical treatment of patients with intracerebral hemorrhage, which we all know is a common disease process that we see frequently enough that we have to manage it on a daily basis, but not as common as ischemic stroke. And until recently, this disease process had not had any successful clinical trials. So it's an exciting new space with new trials and lots of new trials going on now. So I'm going to talk to you about what is the new standard of care for intracerebral hemorrhage, including minimally invasive surgical evacuation. Here are my conflicts of interest, mostly research related. We all know, I assume many people in the line here are neurosurgeons, and so we're all very familiar with this disease process. 15% of strokes are intracerebral hemorrhage. It's very devastating with a very high mortality rate at 30 days and a very poor functional outcome at 25% reach independence at 6 months. What I find really interesting is the patients who suffer intracerebral hemorrhage are disproportionately affected. This is the disability adjusted life years, according to the Global Burden of Disease published in 2021. And you can see that the prevalence of intracerebral hemorrhage is this wedge right here. And you can see the disability adjusted life year contribution of intracerebral hemorrhage is twice that approximately of its prevalence relative to other forms of stroke. So it's a very devastating disease in need of a new treatment. It also disproportionately affects those who are socioeconomically challenged, minorities, and poor patients in the United States, at least. So the questions we've been struggling with in this space for many years are, should we remove the blood? And we have the Stitch trials for many decades suggested that we should not remove the blood. However, the Enrich trial recently showed us that for select patients, we should do a minimally invasive evacuation. If so, how should we remove it? Are all evacuation techniques equal, or should we be very specific in the form of evacuation that we perform? And if so, how important is time? Is it as important as in thrombectomy in this disease process? And so over the last 10 years, there are a few lessons I've gleaned from our experience and also from my own review of the literature. And I think they really come down to three things we can do to surgically, at least, to improve patients' outcome. We can improve the minimally invasiveness of the technique. We know that with craniotomy in the Stitch trials, those trials were overall negative. And it appears there's a general trend with more minimally invasive, the better. Perhaps that's even more important in deep lesions. We want to do a good job as surgeons, removing as much blood as possible. The MISTY-3 trial produced this graphic here, where we have the probability of a good outcome on the y-axis, and we have the end of treatment volume on the x-axis. So the less blood you leave at the end of your procedure or the end of your treatment, the higher the likelihood the patient's going to reach functional independence. This relationship was loosely understood prior to MISTY-3 and then really clearly showed in the data in MISTY-3, and then also became clear when looking back at the data from Stitch 2 that this relationship also existed in the Stitch 2 study. I've also seen it in our own retrospective analysis of our cases. And then looking at time to evacuation. Time to evacuation, there's been a lot of debate about this. Should we go immediately when the patient comes in? Do we have a 24-hour window? Do we have a 72-hour window? And we've gotten conflicting information from trials in the past, but the grouping of the evidence in systematic reviews and also in our own experience suggests that earlier is better. And this graphic I have here is from our own retrospective analysis of 90 cases performing endoscopic evacuation. And here on the y-axis, we have the probability, again, of a good outcome at 6 months. And on the x-axis, we have time to evacuation from when the patient was last known well. We see this loose relationship in our own retrospective data, but this is also played out in other forms of data that I'm going to show you, such that the earlier the patient goes to surgery, the higher the likelihood the patient is to do well at 6 months. Let's look back at the guidelines from 2015 to 2022. We had these American Heart Association guidelines. I know that each country has their own guidelines. In the United States, this is what we use to manage patients. And before 2015, there really wasn't much by way of surgical management other than if you have a large cerebellar hematoma causing neurologic deficits, it should be removed. But there was a general sense and from the stitch data that lobar hemorrhages and supratentorial hemorrhages should not undergo surgery. And there was no evidence for a benefit of that. That had changed by 2022 because we had MISTY 3 but in the interim there. And what we learned in the interim is that we can improve the survival of patients who undergo minimally invasive surgery, at least with the MISTY technique, and that perhaps we can also, and that the jury was out on functional improvement. But then since then, and now that I'm sure the guidelines will be redone in the near future, we have the enriched data suggesting that evacuation within 24 hours with the tubular retractor approach is beneficial for patients' functional outcome over time. I mentioned the stitch trial, so I'm going to go through those a little bit quickly. But in parallel to the craniotomy information that we got from stitch 1 and 2, there have been a whole slew of trials evaluating minimally invasive evacuation techniques. And these are all randomized clinical trials. Here, Auer et al. From 1989 is an endoscopic evacuation trial. Wang et al. From 2009 is a craniopuncture trial, randomized clinical trial. When you take these randomized clinical trials, or at least looking back in 2013 when this meta-analysis was published, there did appear to be an overall signal for favoring minimally invasive surgery over other treatments. And so that continued to drive forward interest in minimally invasive surgical trials, and that continued to drive the formation and the conduct of ENRICH, as well as INVEST and MIND in other trials. In the United States today, these are the three devices that we have that are the most actively used. Here's endoscopic evacuation in the top. You can see a Storrs 3-port endoscope with an Artemis device from Penumbra as an adjunctive aspiration device that gives you an additional degree of freedom when performing the evacuation. And that is all put through a 19 French sheath. So the diameter of that is shown right here. You can see the matching color. This is called a surgiscope. It's a tubular retractor. It's approximately 1 centimeter in diameter, and it has a camera mounted on it. So that is a advantage over the NICO BrainPath, now Stryker BrainPath system, in which the camera is on it and it has very good visualization. So you don't need to have an additional exoscope or microscope to look down the tube. And then they have their own evacuator called the Aurora Evacuator. That's a multifunctional cannula, performs suction, bipolar cautery, irrigation, and morcellation, all in one device. That's being evaluated in a clinical trial in Australia called the Evacuate trial. And we also have an ongoing registry here in the United States called the Mirror Registry. And then we have the Stryker BrainPath, which was the device and system used in the ENRICH trial. So this is the only one right now with level 1 evidence supporting its use, specifically in lobar evacuations. Here you can see the retractor that's used, or at least the trocar for the retractor. Here's the diameter for the retractor in this outer ring here. And so you can see that I'm showing you progressively larger devices, progressively less minimally invasive. But this one right here has been shown to be effective. And this is the Myriad device going down that retractor. And this device has the ability to perform morcellation and aspiration. It also has a light in some variations of it. This device, by the way, can also be used down the endoscope. And so either the Artemis or Myriad can be used with the Storrs Lotta for the endoscopic approach. The ENRICH trial was published almost 2 years, a year and a half ago at this point. This is a 300 patient randomized clinical trial where patients were randomized between surgery or medical management. They had a few unique features, including a Bayesian statistical design, an adaptive trial design based on location of the hemorrhage, and it also used the utility weighted modified Rankin score at 6 months as the primary outcome. At 175 patients in interim analysis, a planned interim analysis suggested that the majority of the signal was seen in the lobar hemorrhages, and due to the adaptive trial design, at that point, no more deep hemorrhages were enrolled, and the trial enriched its population of patients responding well to the treatment, with the only enrolling lobar hemorrhages from that point on. We learned a lot from this trial about the value of minimally invasive evacuation. We learned that overall, minimally invasive evacuation appeared to decrease the ICU length of stay from 9.7 days to 6.9 days. It also decreased the overall hospital length of stay from 18 days to 15 days. It dramatically decreased the need for decompressive hemicraniectomy by a factor of 6. And they were able to meet the surgical endpoint of leaving no more than 15 milliliters 72.7% of the time. So a very effective and feasible procedure that across both populations of location appeared to have some major benefits. But when we look at the primary outcome, it appeared the primary outcome was driven significantly by the lobar hemorrhages. The lobar hemorrhages responded well to this treatment in general. The anterior basal ganglia hemorrhages appeared to not have a treatment effect that was clearly shown here. So the final conclusion from this data is that it appeared to work well for patients with lobar hemorrhages, but not for patients with basal ganglia hemorrhages. So that leaves us with a major question of what can we do for these patients? Some other trials have recently come out since Enrich that I'm going to mention here before I show you some of the techniques we're using here in the United States, at Mount Sinai specifically. The MIND trial is an endoscopic evacuation trial that was recently published in JAMA. And I have these from Adam Arthur's CNS presentation. Patients were enrolled with a hematoma volume of 20 to 80, so a little bit broader than the Enrich criteria, which was 30 to 80. And they were able to be enrolled within 72 hours. So a broader time window and a slightly broader volume range. And the final endpoint was similar. It was the 180-day MRS, not utility-weighted MRS. Utility-weighted MRS was a secondary outcome. And the Artemis system had to be used down the endoscope. That was the system I just showed you. The time to randomization was an average of 27 hours. The time to procedure was 27 hours. So 60% of these were in the quote late time window or beyond 24 hours. And most of the patients were deep, meaning a deep location. 70% of them were deep. So this trial was ended early when Enrich was published or announced. And the results were overall negative. But I think that a lot of information was learned from this trial, such that with the endoscopic technique, surgeons were able to achieve a very good surgical outcome, 81% and 80% across both locations. They were also able to achieve a good functional outcome that was similar across both locations. Similar outcome results were seen in deep and lobar ICH. So this suggested that perhaps a more minimally invasive strategy like endoscopic evacuation might be effective to improve deep hemorrhages in an earlier time window. And the trial, if in a trial that's able to be completed, this trial was stopped early and ultimately did not reach its final endpoint for lack of power. There are other trials going on. There's the Evacuate trial in Australia. As I mentioned, that's an early trial evaluating the surgiscope for early evacuation. And then there's the Dutch intracerebral hemorrhage surgery trial in the Netherlands that is partway complete, doing endoscopic evacuation within 8 hours. So quite a bit of new, exciting literature coming in the near future in this space. I wanted to mention that we just started the MINUTE trial in the United States. This is an NIH-funded 55 site, 300 patient trial. Patients are randomized 1-to-1 between scuba evacuation, which is endoscopic evacuation. That's what we at Mount Sinai have been developing over the last 10 years, first medical management. And the cohorts, it's an adaptive trial design similar to Enrich. However, instead of being adaptive based on location, it's adaptive based on time to randomization. The time to randomization is looked at in 2 windows, the 0 to 8 hour window and the 8 to 16 hour window. Once a patient is randomized, the team has 2 hours to get the patient into the operating room. So we're looking at a surgical window of 0 to 10 hours versus 10 to 18 hours, adding those 2 hours on from what we see here. And the final endpoint is the utility weighted MRS at 180 days. I wanted to show you a case doing endoscopic evacuation, and I'm interested to hear some comments from the surgeons on the line who do endoscopic procedures and maybe even do hematoma evacuation procedures, how similar this is to what you've done or dissimilar. And so here we've got this patient was actually on the elderly side. He was 86 years old at the time he had this right-sided hemorrhage. He was still a very healthy person. He had no other health problems, and he was neurologically normal prior to this. This was an 80 cc right parietal hemorrhage, and this was performed in approximately 2018. So it's been a while since this patient. He's still alive and doing well, actually. But at the time when he came in with this 80 cc hemorrhage with a little bit of IVH, it did break into the ventricle here. His ICH score was actually a 4. So this put him at a 97% mortality at 30 days, according to the ICH score. So a patient, I think many centers would opt for medical management, suggesting that surgical treatment is futile. He met our criteria, our internal multidisciplinary criteria for minimally invasive evacuation. So we did go forward with an endoscopic evacuation. You can see he had a spot sign. He had a likely CAA diagnosis from his MRI findings. And here's the operating room setup we have. This is not his scan, obviously, but here you can see the setup. We do these procedures in the angio suite. You can see here the patient's prone on the table here. There's the sheath going through a burr hole, a 1 centimeter burr hole. Here I have the Storz endoscope in my hand and the penumbra aspiration device. And you can see the view on the endoscopic camera here. When you're in the blood-filled cavity, it's entirely red. And as you wash it out and aspirate the cavity, it clears up. And when you have a completely clear view, you know you're done. I was able to get a complete evacuation for this patient. You can see there the coronal pre and post-op. Here you can see the sagittal pre and post-op. And if I see a hematoma like this, I try to approach it down the long axis so that the hematoma collapses around my aspiration tool as I'm performing the evacuation. And here you can see where my burr hole was. And you can see I got out most of that blood or all of it by washing and irrigating. I did encounter a bleeding vessel that I was able to treat with the endoscopic bipolar that comes with the Storz kit. It's a firm bipolar. This is how the patient did. He had an NIH stroke scale of 17 when arriving. And then when he got extubated on post-op day 1, he was down to an 11. And then over about a week to 10 days, he had some subtle improvement in his left side. And then by 30 days, he had significant improvement and he was a professional piano player, he's back to playing the piano. And here he is playing the piano in his rehab at 30 days. And then back at 90 days, he came into the office and here he is. He walked in and he was talking to me and sharing some of his thoughts about the entire experience he had. And so we all learned from this particular case to evaluate each patient independently if they fit the criteria for minimally invasive evacuation. Even if they're on the elderly side, such as 86, they could still benefit from this if they have a healthy baseline and if the procedure is done in a timely fashion and with a complete evacuation. I wanted to show you a little bit more specifics in a case. And so I wanted to sort of bring you through our setup in a little bit more detail. And so I'm going to kind of fast forward here to one of our cases here. This patient is a 55-year-old who came in originally with a stroke scale of 4. So he was minimally affected from a small basal ganglia hemorrhage, but then it expanded and worsened to a 15 and a 30 cc hemorrhage. Here's the 30 cc hemorrhage that you can see here after he had his expansion in the first few hours after he arrived. So it's a basal ganglia hemorrhage, a deep hemorrhage, the focus of the minute trial. Because he was a young patient, he was 55, and he had a spot sign on CT, and he had expansion. I performed an angiogram. As I mentioned a few minutes ago, I do these procedures, the evacuations in the angio suite. So it's very easy for me to put the patient on the table, do an angiogram, and then convert right away to an open procedure if the patient has a clean angiogram with no hint of an AVM. So for a younger patient or with any question from the CTA, I'll do an angiogram and then move forward with the evacuation. Here's an ultrasound picture through the burr hole. You can see the hematoma there. You can see the midline and the hematoma here in the basal ganglia. This is the approach I like to take. I like to go straight down the long axis, as I mentioned, so that as I aspirate, the clot is symmetrically being aspirated and the cavity is symmetrically closing down around the catheter, the aspiration catheter. And so often that does bring me to the forehead where I'll do a 2 centimeter incision and a 1 centimeter burr hole. This is kind of a cartoon illustration that you saw earlier of the instrument going down the sheath. And here's what it looks like from inside the endoscopic view. And here's the aspiration tool coming in. And I'll generally work within the sheath. And you can see there's some blood coming into the sheath already. And in this case, now that I've aspirated, I've detamponaded, something is active in there. I can tell from the orange color and the red color of the blood. but I continue to irrigate and I continue to aspirate whenever I see anything come in, and I wait a few minutes, maybe 5, 10, 15 minutes until the cavity starts to clear up with continuous irrigation. And I'm seeing if I can find what's active. And now, about 20 minutes into the procedure, you can see I'm looking for the active bleeding. I can see the back wall of the cavity, and I'm still irrigating and not letting any new blood accumulate on the inside because of the constant irrigation with lactated ringers at a slow rate, but in the cavity, it does clear it out very nicely. And I'm touching up these with very gentle aspiration, the residual blood clot, making sure I've got the cavity as clean as possible until I find that bleeding vessel. And then I can put my irrigation right on it, see where that's coming from. And you can see it's kind of coming from the wall of the cavity up here. And then that's a bipolar cautery going through the Storslot endoscope. And I'll activate that. And it's very effective at cauterizing and stopping any bleeding. And then finally, an hour into the procedure or so, I'm able to very clearly see there's nothing active. And I can see with the irrigation that it's a very clean cavity. I pause the irrigation. I see if it becomes muddy again from some bleeding that I couldn't see. And then I slowly pull the retractor out while looking at the wall of the tract and making sure there's nothing active in the wall of the tract, really making sure I've got complete hemostasis as I come out of there. Here's his post-operative CT. You can see a few drops of blood in there, but less than a cc. And you can see the brain having closed down around there. And now you can see some decompression of the right lateral ventricle, definitely decompression of the midline structures. Here's an AI generated measurement of his post-op scan. And then here he is. I was teaching a course on how to do this, and he agreed to come down and say hi to everybody before he left. You can see he's still got his um, hospital. He just had his IV taken out. You can see he's got his bandage there where the IV was. And he completely recovered strength on his left side. He completely recovered his cognition. It took him a few days. This is post-up day 4 when he left the hospital. And he's gone back to work, and he's been doing very well. Um, I wanted to show you a little bit about our system because it really matters a lot how you triage these patients in your healthcare system. At Mount Sinai, we have 7 hospitals within the healthcare system, and then we have a number of hospitals outside the healthcare system who regularly refer patients to us, even in the emergent setting. And so I wanted to bring you through how that system works, and then kind of stop and see what kind of questions and what kind of discussion you'd like to have. So this is a patient who was a tourist traveling from Indonesia when he had a sudden loss of consciousness with his family in New York City. And he was found to have this hemorrhage when he was brought in emergently to our emergency room. It was measured at 19 cc's by using this VizAI as this automated app that we've had for a few years now that gives me the volume and alerts my team right away when there's a patient eligible for surgery or a trial. You can see he had a spot sign. So I brought him right away to the angio suite within an hour or so, and just kind of going through that a little bit faster. And when I got him to the angio suite, I did a Dyna CT, and the Dyna CT, a cone beam CT, showed the hematoma had expanded a little bit, and you can still see a little contrast gathering where that spot sign was on the original CTA. So he was elderly, so I didn't do a angiogram. I went right to the evacuation. And here you can see kind of a cartoon of that. Here's what the setup looks like in the angio suite. I do use stereotactic navigation, but I use EM, electromagnetic navigation. So I don't have fiducial on the patient's head. I just have a sticker fiducial rather than a frame. So this patient's not fixed. They're on the angio table with a donut under the back of their head. And you can see the incision here on the left forehead. And here you can see fish hooks being used to retract in a 1 centimeter burr hole. Here's my burr hole ultrasound that I use to get a pre and post evacuation image. And then the setup I was showing you with the Artemis device going through the endoscope to give an additional degree of freedom for aspiration. I don't like to aspirate directly through the endoscope. I like to aspirate through this device. And this device also morcellates the clot. So I can watch while I'm aspirating and make sure I don't collapse the cavity or aspirate anything on the cavity wall. And here I've got irrigation going in one of the side ports here. When we describe this technique, we've broken it up into really 2 phases. First, a debulking phase in which you have the aspiration's set a little bit on the higher side, and you're aspirating a lot of clot, making space. And then once you really start to see some space, turning up the irrigation and filling out the cavity and exploring for bleeding and exploring for residual large pieces of hematoma that you can gently aspirate off the wall if it seems like it's worth it, if it seems like it's big enough to merit going after. And here's what this looks like trying to treat this spot sign. You can see this very large spot sign, kind of complex vascular tangle that I got myself into trying to treat here. And I wanted to show you some of the techniques we use here in the scuba technique to treat something like this through the endoscope. First, I'll irrigate and for a few minutes and see if something will stop just with irrigation alone. Then I will add liquid thrombin on the side port. And here, over here, you can see I'm attaching a syringe to the side port. I'll stop the irrigation. I'll inject 5 cc's of 5,000 units of thrombin, diluted. It's liquid. It goes in, and then right away you start to see coagulation occurring. And in many cases, I'm able to stop bleeding. Not very active bleeding, but I'm able to stop oozing and light bleeding with that technique. So I'll do that, and then I'll turn on the irrigation after five seconds or so and wash out the thrombin and wash out any new blood that's accumulated. In this particular patient, I did that. It worked for a little bit, but then as I was doing the rest of the evacuation, some bleeding started again from this area here. So I ended up coagulating it. And here you can see the bipolar coagulation. So really, those are the three escalating techniques for endoscopic hemostasis. You've got the irrigation strategy with continuous irrigation. Then you can inject liquid thrombin. You can also use bipolar cautery. Some other people like to inject Surgiflow. I like to keep good visibility in there, so I kind of veer away from Surgiflow, but other people do find that very effective. And here's his post-op evacuation scan, which I do on the table in the angio suite using a cone beam CT. So I don't close up. I have not closed this incision. I have not put a burr hole there. I just take out the instruments. I put a gel foam in the track to make sure no blood drips in, and then I'll put a towel on. And then I'll do this. I'll do this CT and verify I've met the surgical endpoint. Surgical endpoint is 15 cc's or less being left in the cavity, and that certainly was met here. And then here's the patient's post-op day one. You can see a few drops reaccumulated in there, but really very minor. And here's his MRI. You can see very little perihematomal edema around that. In our first 100 patients doing the scuba technique, we wrote up the results that we achieved, and you can see an evacuation percentage of 88%. The deep hemorrhages in the minute trial, the NIH funded trial that I mentioned, the target is 10 cc's. Some other trials, such as a reevaluation of the MISSI data, suggested that maybe 6 cc's is the new target for basal ganglia, but that's something that there's more investigation needed. And I think with that, I will stop and see if there's any questions or any discussion.
Thank you, Professor. Uh, it was a marvelous lecture. We have some questions here. We have regards from Mumbai, India, from Dr. Harshad Parekh. And we have a couple of questions from Professor Suju. Thank you for this useful lecture. I have some questions from Technical Point. First question is, do you use endoscope holder?
There are some people who use the Mataka arm or another endoscope holder. I myself have not used that. I do like to move the endoscope and the sheath around during the procedure so that I can explore the cavity and I can use the sheath to direct the irrigation. However, many of my colleagues use the Mataka arm for the sheath or the endoscope. So I think that's a very valid strategy. And certainly there are many times when I'm irrigating and waiting for bleeding to stop where I wish I had that set up in my operating room. So great suggestion. The irrigation I've been using is lactated ringer. So I'll go through 2 to 3 liters in the procedure. Some people have talked about cooling the fluid. Some people have talked about warming the fluid. I have been leaning towards slightly cooling it. It's not very cold that I can feel it really in my hands, but it's a little bit cooler than room temperature or what I've been using. Um, and then a 4-liter bag is a great way at shoulder height to get enough irrigation force that it dribbles out at a good rate, but you definitely don't want it coming out too fast at the end of the endoscope because you don't want to cause any damage with irrigation itself.
Mhm.
I do use a disposable introducer. I know that the stores and the Minops have their own introducer that's a metal introducer. I've been using the Escalap 19 French introducer. I do find that to be very easy, atraumatic, and I like using that. Um,
And there was a
and then
question I skipped, I'm sorry, in the before that. Viagu is asking, is there any pre-operative survival score used in an endoscope?
the pre-op survival score, I've been using the ICH score. Um, my team did validate the use of the ICH score in our own patient population. I agree with you. It certainly can be now reevaluated and perhaps improved on now that the survival appears to be different when the patient undergoes minimally invasive surgery. So that's a great suggestion, whoever made that. I think that there will most likely be a minimally invasive surgery survival score. Other factors that come into play that impact outcome for patients who undergo minimally invasive surgery, we know are how early you get to the room, what your evacuation percentage was. So these may not be initial presentation factors, but they might be procedural details that can go into modeling the patient's long-term recovery or survival. So great suggestion there.
Thank you. And Dr. Celine Buzdag is asking, when planning endoscopic evacuation of an intracerebral hematoma, which principles guide your selection of the surgical trajectory? And do you prioritize the shortest distance, avoidance of eloquent fiber tracts, close consistency patterns, ventricular proximity, or hemostatic control strategy?
Great question, Dr. Bozdag. I like to work along the long axis. I would never go through an eloquent region when choosing that. So I suppose the highest priority is avoiding eloquent regions and eloquent fiber tracts. I find that most cases I'm able to operate from a frontal approach or a superior parietal approach if the patient's prone, like that one I showed you with the elderly patient. Then after that, I don't really make decisions based on what I suspect the clot consistency will be or the ventricular proximity. I do really like the long axis principle. When you get into a cortical hemorrhage that has a large surface area on the surface of the brain and then goes in those cases, I'll try to position right over the hematoma and I'll do a little bit larger burr hole so that if the endoscopic approach I run into trouble, I find myself in bleeding with a live vessel in the cortex, then I can look directly in and I can do part of the procedure with a direct evacuation.
Thank you, Dr. Ertan Sevin. Thank you for your presentation prepared with theoretical and visual information from Katip Celebi University, İzmir. Thank you, Dr. Ertan, for your comment. Dr. Harshad Parak from India, Mumbai is asking, what is your experience in terms of clinical improvement difference in STD, micro, and endoscopic approaches.
Okay.
Standard.
Um, I
Stereotype.
think I think there's a lot of potential for I think there's a lot of variation for how you can do these procedures. I think the main principles are you have to do it early, especially with basal ganglia hemorrhages, and you have to get the blood out and be sure that you don't have any light bleeding. The microscopic technique, what was evaluated in stitch 1 and 2, and it was negative, but we didn't know as much as we know now about what we have to get out and when we can do it. So perhaps there's still an opportunity to do microscopic evacuations. I find endoscopic evacuations, particularly with deep hemorrhages, I can achieve a good outcome almost all of the time by improved visibility and washing the cavity. Occasionally, when a patient emergently comes to a hospital in which I don't have an endoscopic setup, I will do an open microscopic procedure. And most of the time that goes well, but I do occasionally find myself surprised by some pocket of the hematoma I did not see, or some residual hematoma, or some recurrence of the hematoma, perhaps because of some oozing that I did not recognize. So I think that that's, what you're the most comfortable with, but there is a little bit of data suggesting overall the microscopic approach did not seem to work out, at least in the trial data.
Thank you. Dr. Murat Özkalkanlı is asking, thank you, Dr. Kellner. I'm the anesthesiology doctor for neurosurgery department in Atatürk Training Hospital. First question, does the anesthetist prefer local techniques or super selective scalp blocks in selected patients? And did you ever try this technique for hematomas that occur bleedings from the cranial
Okay.
mass evacuation?
Okay, also great suggestion. And I would be interested to see if anybody has a series of awake evacuations with scalp blocks or selective local techniques. I have always done it under general anesthesia, but sometimes I have wished that I could extubate the patient after the procedure and the patient remains intubated for longer than I hoped. So I do think there may be a role for that. Sometimes the procedure is really 1 to 2 hours, so you'd have to make sure that the patient were able to tolerate that length of a procedure with a local technique. But I do think that is feasible, and I'd be interested to see someone try that, although I don't think in my setting it would work very well.
Thank you for an honest response. Dr. Harshad Parekh is asking, is there a difference in results in left or right side of brain in terms of clinical results?
There hasn't really been in the trials so far, so that I don't take that into account in my decision making. The things I take into account actually, which are a little bit incorporated into that, is the NIH stroke scale. I really try to think of these patients as a stroke patient, and I'm evaluating their potential response similar to a thrombectomy evaluation. So I will use the stroke scale, and we use the stroke scale of 6 or greater for a patient to be eligible for the procedure. So they become eligible a little bit easier if the hematoma is on the left side and they've lost language. But I wouldn't say that I would exclude a patient on the left side because of their recovery potential. I feel like the recovery potential is strong on both sides for select patients.
Thank you very much. I don't see any more questions in the chat part. Maybe I have one question. Like, what is the not the percentage, but probably the estimate of the patients that because of the perifocal edema required the decompression surgery, especially in the young population, if
It's
you have
less
such cases. Yeah.
it's less than 5%. If you get a good evacuation, I think it's possibly zero if you get a good evacuation. The once or twice in my entire experience doing this 400 times now that we've done it. Been because I haven't gotten a good evacuation. There's been residual blood, and there's been continually mounting cerebral edema related to the presence of that blood. The MISTI 2 data and also MISTI 3 information presented and also ENRICH data presented but not published suggested that removing the hematoma overall actually decreases the cerebral edema. So that relationship has been shown in a few trials. So perhaps if you get out most of the blood, you're able to reduce the edema and prevent that escalating edema issue you run into if you're medically managing a patient. I see that last question there from Dr. Parekh.
Yes.
I certainly
Would you?
recommend early surgery rather than waiting for deterioration. I think that the benefit of early surgery are multifold. One benefit is you can mitigate expansion, perhaps, if you're able to get in there very early and treat the bleeding vessel with cautery. Then that's one way. So that patient who had a small hematoma never turns into a patient with a large hematoma. The earlier you go, the perhaps the more you can mitigate the mounting inflammatory response and secondary injury. So I think those are really the two reasons that I see early as better than later. But also there's data suggesting earlier is better, across the trials that have been published. There was a Dutch meta-analysis, a meta-regression by Sondag et al., looking at the time to evacuation and the outcome of all the trials, showing that the trials that showed a benefit were the trials performed in early time windows.
And we have another question from Taha Aktash. During endoscopic evacuation of ICH, have you observed any patterns in how the clot consistency, soft, vice versa organized, affects the surgical navigation and the risk of rebleeding? And do you modify your technique based on these patients?
Okay, thank you, Dr. Ashash. what I see affecting clot consistency is really only one thing so far that I can tell, and that is whether the patient's been reversed with platelets or anticoagulation. My team recently published a paper in the Journal of Neurosurgery a few months ago showing a clot consistency score that we developed. It's a 1 to 5 scale and looking for factors that correlate to higher clot consistency. And the only thing that came out of that in looking at approximately 200 patients was who underwent endoscopic evacuation was whether the patient had been reversed, if they'd had anticoagulation that got reversed, or if they were on had antiplatelets where we gave the patient platelets. Those clots seemed to be harder to get out, and the consistency was more fibrous. In that case, it is more challenging to perform an endoscopic evacuation. Certainly not impossible, and I wouldn't change my evacuation strategy based on that. But that is the only factor, more so than time. I don't see a time-based clot consistency effect. I know that it seems like maybe over time they would get softer, but some patients still have fibrous clots later, within the 24-hour window. So um, that's really all that I've got to say on that.
Uh, Thank you. Another question from Rahil Rafik. Is there any pressure you set for the fluid inflow or infusion?
I just put it at shoulder height and I use cysto tubing. So it's a little bit thicker tubing that you saw in that picture. And um, based on that, I make sure I look at it when it's coming out of the endoscope and I make sure it's not coming out like with a trajectory that it's just dripping out. So um, you could theoretically increase it, but I feel like if you increased it, you might perhaps damage the wall of the cavity from the inside if you have a forceful irrigation stream. So
Mhm,
I'll do it light, but coming out with a consistent drip, drip, drip, drip.
mhm. Thank you. Dr. Obiagu Ken is asking, after how long do you start pharmacological DVT prophylaxis?
That's also a great question. I have seen um, patients. I think there's a strong benefit to earlier starting. So actually, what I do is I start it um, the day after the patient has arrived. After I get a 24-hour CT, I'll start it right after that if that has shown no rebleeding after my surgery.
Mhm,
And our own data suggests that that is beneficial. We were starting it, within 48 hours with some early and some within the 24, 48-hour window. And we did have a few DVTs and one PE that resulted in a mortality with that late start. So our own data, and we're about to publish this, does suggest that earlier starting is beneficial within 24 hours.
mhm. Thank you very much. And Dr. Jipaji is asking, is there a possibility of having an concomitant aneurysm envisaged, example, MMA aneurysm in temporal lobe? How do you deal with this?
Um, I do a CT CTA with every patient. Having that CTA is a prerequisite for undergoing a minimally invasive evacuation or even a surgery of any form. If it's an emergent case, I wouldn't do an endoscopic evacuation. If I don't have the opportunity to get a CTA, I wouldn't do a minimally invasive case. Fortunately, in our institution, when a patient arrives with stroke-like symptoms, they automatically get a CT CTA. So everyone has it. If there's anything suspicious on that, or if the clot comes to the fissure, then perhaps I'll do an angiogram. I have had aneurysms. I have had patients who have had subarachnoid hemorrhages with hematomas, and then I have done endovascular embolization, then done an evacuation immediately following that in the same setting. And I find that if you can completely coil the aneurysm, there's no problem with that. And I can recall in one case doing the evacuation and seeing the aneurysm, just staring it right in the face through the endoscope. And that worked out okay. But you've really got to make sure you've got that aneurysm treated well.
Thank you very much. Fascinating. Do you always perform it in angio suit, or like is this how you started, or is this how you decided to after experience?
Yeah, we have some advantages to the angio suite that are really systematic in our institution where I always have access to it. I always have two rooms. Always have a team available. So for me, it's the room that's always available. I don't have to negotiate or bump any other surgeons. So there's some benefit to that. Also, we're doing thrombectomy frequently, and it's the same emergency team. So I've got a team on call who can float between both procedures. So there are some aspects that make it beneficial. I also like having the cone beam CT that I can do with the patient on the table. If I had a good O-arm, perhaps I would do it in the operating room instead. And I see no problem with doing it in the operating room, getting an intraoperative CT there. It's just that in my system, it works better than the angio suite for me.
Thank you very much. Professor Suju, would you like to comment or ask your questions?
No, I just want to thank Dr. Christopher Kellner. Thank you so much. It was very useful lecture for us. Also, I want to thank everyone who joined us. Thank you.
Thank you
Thank you
very
very much
much.
for inviting me. I really appreciate it.
Thank you. Bye.
Thank you.